Well, I'd once again like to very much thank Dr. Gupta and the organizing committee for inviting me to speak today. And this session will serve as this talk will serve as an introduction to the subsequent talks. And I'll show you how I approach using OCTA in the clinic and in clinical trials. So by way of outline, I want to put the talk in context, and then I will mention some of the methods that I use to interpret OCTA, and then I'll provide some real-life examples. I think when you consider the advantages and disadvantages of this technology, it really brings to light the utility of using it in the clinic. And I think it also then highlights some of the unmet needs with this technology. You're all familiar with the advantages, which include the ability to see depth-resolved blood flow, the retinal vascular architecture. You don't have confounding leakage. It's non-invasive, and you can acquire images relatively fast. And here you see the leakage that obscures vascular detail on the fluorescein angiography image on the left, whereas in the right you can see that the leakage is not obscured because you don't get leakage on OCT angiography. At the same time, though, there are disadvantages. Although it doesn't take very long to acquire the images with most of the systems available, it can take a long time to interpret the images if you do it properly. And although it's an advantage that you don't see leakage, it also can be a disadvantage to not see leakage because you don't have that potential to identify, for example, VEGF-driven pathology. There's a relatively small field of view that's highly resolved with this technology, and there are artifacts, as I mentioned. To overcome the disadvantages, automatic algorithms have been developed, deep learning approaches have been used to try and speed up the interpretation time, which, as I mentioned, can take a while in a very busy clinic. Recognizing the artifacts, and particularly software to remove those artifacts, has been very helpful. You can montage images to overcome the small field of view, and faster scanning times will help with the resolution. And this just illustrates the problem of the field of view, and that the lesion, in this case, was at the limits of the field of view, and you really don't know how far it extends below there. If you look at the resolution, I think you can appreciate this is a 3mm area taken from a larger 6mm scan. And you can see that the difference in the resolution of the vessels is much greater on the 3mm when compared to the 6mm image. Now, I did this in the clinic and took images from our photographer who had taken them different fields with 3mm scans, and I just stuck them together on the computer and montaged them. You can do this automatically now with the computer software, and when you do this, you can eliminate that problem of having the images at the limits of the field of view. So how would I use this technology in the clinic? I actually think of structural OCT like an ocular vital sign, and I obtain it on almost all the patients that I see in the clinic, but I don't think of OCTA in that way. I think of it more like I would use a fluorescein angiogram, where I will use it when I think it helps with the diagnosis and monitoring of the patient, but I don't get it on every patient. And I think this is similar to the very early days of OCT, structural OCT, where we weren't exactly sure the best time to use it and use it in a more limited basis. But I think it's also particularly helpful for multimodal assessment. And I mentioned the artifacts, and there are a whole bunch of them. There are many more, actually, that you get with OCTA than what you get with structural OCT. You get all the same ones you get with structural OCT, and then some. So those include shadowing, signal attenuation, segmentation artifacts, motion artifacts, projection artifacts, and false negative blood flow, those latter two ones that you don't see with structural OCT. And to help recognize those artifacts, I think it's really helpful to look at the cross-section B scan with the flow overlay. And that can very much help you to identify the artifacts. So if you were to look at the en face OCTA here, you see the shadowing. But immediately, when you look at the cross-section, here you might not be able to tell immediately whether it's a flow void or whether there's something superimposed in the vitreous. If you look at the cross-section, you can immediately tell that it's shadowing from an overlying vitreous opacity. You can get this reverse shadowing effect also from the blood vessels casting shadows, and then you can see the reverse lucent areas corresponding to these false vessels. Motion artifacts also result in a misalignment of the vessels that you can readily detect, and then you can remove these with the motion artifact removal software, and you can see how now the vessels are in register. It's really important also to identify the level that you're at, and that's where I think the cross-sectional flow map is particularly helpful. And pigment epithelial detachments are in particular very difficult with OCTA to often get the correct plane. And so you can see that if the slab is too high, in this case, you completely miss the choroidal neovascular membrane. So you have to look at both the cross-section together with the en-face map, and if you move the slab down, now you can see the vessels properly. And just to remind you of the OCT angiography in a normal eye, you see the vessels in the superficial layers. You should not see them in the deep layers. But then you get projection artifacts, and sometimes these are not so much of a problem. Here you see at the arrows the projection artifacts that are projecting into the deep layers that can be removed with the software, projection artifact removal software. I don't think you'd have much of a problem identifying the choroidal neovascular membrane here with or without the projection artifacts. But in some cases, it can be problematic. So does this flow void extend all the way out here, or is this a real vessel, or are these projection artifacts? When you use a projection artifact removal, you'll see this flow void actually extends farther than you might think, and this is actually a projection artifact. So what about using a multimodal approach? So here you see the fluorescein along with the ICG, along with the OCT angiogram, and I think looking at them all together really can give you a better appreciation of what you're actually looking for, particularly in eyes with PCV. So you see the characteristic findings on structural OCT with the double humps. You see the areas on ICGA with the polyps, and with OCTA, I think knowing what location you're at with respect to the slab is very important, and I think it will help you avoid missing some of the lesions. So here you see the polyps, here you see the branching vascular networks, and they can be superimposed on one another, but they may not be at the same level. And this was a paper, I thought, a beautiful paper by Chi and one of a former Duke fellow, Cheng-Kuo Cheng, who showed that the polyps are actually mostly located on the inner aspect of a pigment epithelial detachment, whereas the branching vascular network is either on top of, within, or under Bruch's membrane. And depending on where you place your slab, you may or may not be able to see the structures. So you need to adjust the slab to see the different layers. With RAP lesions, OCTA can also be quite helpful, and you see it in the fluorescein with the ICG and on structural OCT, but then as you follow along the OCTA, you can see the flow void, you see the flow, which you see very nicely on the cross-sectional flow overlay. And as you follow these lesions, here you'll see the area on OCTA, the hot spot corresponding to the type 3 neovascularization. And just to show a few clinical examples to finish up, this was from a former Duke fellow who had a patient that had subretinal fluid in both eyes. It was refractory in one case to the anti-VEGF therapy. It received multiple intravitreal bevacizumab injections. This was a PXE with a vitelliform-like lesion in both eyes. The fluorescein didn't really show clear choroidal neovascularization, but on the OCT angiogram, there was a very clear area of choroidal neovascularization in the right eye, and so this helps tell you that this may be the eye that can respond to therapy. And so the patient elected with continued anti-VEGF therapy, and in the right eye, it actually had a beneficial effect. In the left eye, didn't make much difference, and that's because the choroidal neovascularization associated with the vitelliform lesion, which you could identify with the OCT angiogram. Here's another case of an idiopathic choroidal neovascular membrane, and this was an eye that had had previous submacular surgery when we were doing that for choroidal neovascularization. There was no fluid, and so the question is, does that mean that there's no blood vessels remaining? You could actually see remaining choroidal neovascularization even after the removal, and these were clinically silent. So you could tell that they were there, but they really weren't causing much problem. Here's another case where you see the eye that had unexplained vision loss and visual acuity 2100. There was retinal thinning on the structural OCT. And when you go back and here you look on the OCT angiogram, you see this large area of a flow void. Now, why would this have occurred? If you look back at the patient in 2014, several years before, you see this area of ischemia. This was actually an arterial occlusion, and this whitening then corresponded to the later flow loss. And just finally, you see these areas of hypocyanescence. This is a serpiginous TB variant that after treatment, the flow voids recovered. And on this last case from Dilraj Grewal, who's going to be talking tomorrow, you see these multiple lesions of cryptococcus, the hypocyanescence corresponding very well to flow voids that were seen, on the overlay with the OCT angiogram. So in selected cases, a multimodal approach will allow you to use this in a very effective way. The indications are evolving, and I think with improving software, particularly improvements in interpretation software, which will help you do this quickly in the clinic, this may become one of the ocular vital signs. Thank you very much.
Thank you, Glenn, for summarizing the whole thing where we stand as far as OCTA is concerned. Now we call upon Andrea Coe for his talk on retinal biomarkers for disease prognostication.
Thank you very much, Chairpersons. Also a great thank you to Professor Vishali Gupta and the organizing committee. It's really great to be here in Jaipur and to see so many old friends and to meet new ones. I've been asked to speak on retinal biomarkers for disease prognostication. And actually, the session this morning was very helpful because we've already covered some of the qualitative markers which I feel play a role in prognosis. These are my financial disclosures. We're all familiar with the layers of the macula, and I think as OCT has evolved, so has the practice of retina. I think, can you remember the days that we had to see patients and decide on management without the OCT? I think it's quite difficult to do so now without, as Glenn has mentioned, one of the vital signs of ophthalmology. If you look across the board, OCT has played a role in many areas as biomarkers. A biomarker is an indicator of either disease prognosis or response, or no response to treatment. You can broadly classify into quantitative and qualitative. But suffice to say that the quantitative biomarkers, despite having a good correlation, for example, if you have a very high central subfield thickness, quantitatively you have poorer visual acuity. You have greater visual acuity gains, but final vision may be worse. But really quantitative correlation with prognosis is poor. So I will limit my talk to largely qualitative and morphological structural changes on the OCT, which I feel are more instructive. I'll start off with AMD and just say a short few words about diabetic retinopathy. So let's start with fluid. We know that fluid can accumulate in different compartments in the OCT, and it's really the spectral domain OCT that gave us a greater insight into the different compartments. In the past, we lumped it all together in macular thickening or no macular thickening. Now, what is the significance of each of these compartments? First, I think intraretinal fluid. More and more, we are seeing that intraretinal fluid is by far the most important prognostic factor and biomarker in the OCT. There is a great correlation between baseline visual acuity and visual outcomes in all our neovascular AMD treatment. Up to 60% of the actual vision in our treatment-naive eyes can be explained by the presence of this intraretinal fluid. It's most associated with classic type of choroidal neovascularization, type 3, rat lesions, as well as late-stage occult, CNV. In other words, when we see intraretinal fluid, it indicates either a more aggressive type of lesion or a late presentation, and therefore a poor prognostic factor. This is data from the CAT. You see that presence and persistence of intraretinal fluid, so you can see no fluid versus presence and persistence at week 52, resulted in a far worse outcome. If you have intraretinal fluid at the fovea, you have a worse outcome than if you have subretinal fluid or sub-RPE fluid. But the key differentiation really, I feel, in this day is between fluid, which is from activity, which is exudative, versus degenerative type of cystic hyporeflective spaces. So we call them degenerative intraretinal cysts. Now, how do we distinguish between them? I've listed some of the important features. But the main one really is that in degenerative, there is no response to anti-VEGF treatment. So if you are unsure you can give a trial of VEGF, anti-VEGF treatment, and if you don't see a response, you stop. And when you stop therapy, it doesn't mean you discharge the patient. You can watch for reaccumulation or enlargement of these fluid spaces. And then you know then that these are exudative rather than degenerative. Very often, they can coexist, and that makes it really tricky. Some spaces are degenerative, but some are exudative. What about subretinal fluid? The majority of patients with neovascular AMD at some point in the disease will show subretinal fluid, mainly in the occult type lesions. And in fact, it is not a bad thing. Subretinal fluid, when present, is associated with higher vision levels at baseline and larger vision gains with anti-VEGF treatment. When it's present, it really doesn't quite matter how often you have to treat. You can use a PRN regimen, you can use a monthly or treat and extend. They do fairly well. Why is that so? Probably because there is a protective, perhaps a protective effect against RPE atrophy. It has been postulated that you need functioning RPE and photoreceptors in the foveal area for subretinal fluid to be present, and the perfusion of the choroidal neovascular complex might really act as a survival factor. So in short, subretinal fluid is not a bad thing, it's a good thing. When you have subretinal fluid, it did not really matter whether you gave anti-VEGF treatment more frequently or less frequently. We are all familiar now with the very detailed work that the consensus team, which includes many of the people and experts in this room, in this paper in 2014. And I'm highlighting the ones external limiting membrane, ellipsoid zone, and the RPE line because the outer retinal bands have good prognostic factors, are good prognostic indicators of disease. The integrity of the outer retinal bands is now recognized as an important factor for visual acuity outcomes. So significant correlation, especially with the external limiting membrane and the ellipsoid zone. It is not as predictive of visual acuity change compared to intraretinal fluid and subretinal fluid. And sometimes with successful treatment, you treat exudation, the outer retinal band disruption may actually improve, and this tells you that there is a potential for improvement in visual function. The ellipsoid zone has been largely talked about. I won't repeat it, except to say that the nomenclature has changed. In the early days, we were talking about ISOS, inner segment, outer segment junction. You read the paper, you will see why it is no longer felt to be so. And the ellipsoid zone really corresponds to this area of tightly packed mitochondria, giving you that hyperreflective band. There has been some controversy about the role of integrity of the ellipsoid zone. For example, this paper from Taiwan showed a correlation between initial and final length of the disrupted ellipsoid zone. But in this paper with the Koskas group in France, there was no correlation between the ellipsoid zone restoration and visual acuity, but only with the external limiting membrane. So I think it depends on the evolution of the disease and perhaps the chronicity of disease. This is an example from the paper where after 18 months of aflibercept therapy, you see that the length of external limiting membrane disruption has greatly reduced with increase in visual acuity. We already talked quite a lot about subretinal hyperreflective material. I won't need to go too much into detail except to say that they are associated with poor outcomes. Hyperreflective foci or dots are not just found in diabetic macular edema, they are found in all kinds of retinal diseases. They're thought to be activated microglia and signs of inflammation. They are thought to be an early sign of RAP and associated with poorer outcomes. We find this in wet AMD, of course. When you treat, you have a significant reduction in the hyperreflective dots. So maybe inflammation does play an important role after all. Again, outer retinal tubulation has been covered. It's often misdiagnosed as intraretinal fluid. The key here is not to overtreat if you have outer retinal tubulation. Choroidal thickness also is important, I think, in the context of thin choroids. These are patients who have poorer prognosis and a higher risk of geographic atrophy. Looking at AMD in general, we use the choroid in differentiating between PCV, polypoidal choroidopathy, which tends to be associated with a thicker choroid. And also the Taiwanese group also showed a baseline choroidal thinning as a negative prognostic factor. You heard from Glenn earlier about OCT angiography. I think that this is still an evolution. We don't always are able to use the OCTA in our retreatment decisions, but in the future, I think it will play an important role. I use it to differentiate between active and quiescent CNV lesions. Now, very quickly, just in diabetic retinopathy, some are the same as AMD. You've heard from this morning also the importance of drill, this organization of retinal inner layers. That is important mainly in intraretinal disease, such as diabetic retinopathy. The number of hyperreflective dots in diabetic retinopathy, it also correlates with the severity of DME as well as the severity of diabetic retinopathy. Here you see in patients with NPDR versus no DR a significant increase in hyperreflective spots. This is the presence and absence of drill and the correlation between central subfield thickness and drill length with visual acuity change. In other words, if you have a short drill, you have a better chance of vision improvement. So to summarize, OCT has now become for us an indispensable tool in the modern age. It has facilitated, of course, our treatment with anti-VEGF. There are paradigm shifts towards looking at specific morphological change which are relevant for visual function, treatment outcomes, and disease management. And I think OCT biomarkers will continue to stay and will be able to refine and help our patients. Thank you very much.
Thank you very much, Dr. Andrea Coe, for summarizing the whole where we stand as far as the biomarkers are concerned. Now I call upon Bailey Freund. What does dense B Scan OCTA tell us about type 3 macular neovascularization?
Thank you, and thank you to the meeting organizers, particularly Vishali, for inviting me to this wonderful meeting. So I'm going to be talking about some new concepts in type 3 neovascularization, also known as retinal angiomatous proliferation. A brief review. About one-third of newly diagnosed neovascular AMD in white patients is this lesion type. If you look for it with multimodal imaging, these patients are at high risk for bilateral disease and for macular atrophy. The clinical findings of type 3 neovascularization are intraretinal hemorrhage and fluid. Hyperpigmentation is very common, and these patients may have soft drusen, or they may just have subretinal drusenoid deposits or a combination of different types of drusen. Here's a patient just with subretinal drusenoid deposits. You can see the OCT findings, which are the intraretinal fluid and the intraretinal hyperreflective lesion. Now here's the findings with OCTA. We're going through the en face image, and you can see the retinal vessels connecting to the lesion there. It's fed and drained by retinal circulation. There's no evidence of retinal choroidal anastomosis in these early type 3 lesions. Here's looking at the different slabs. This is the full thickness, so we can see the entire lesion with swept source OCTA. Here's looking at just the superficial vascular complex. You don't see the lesion in the superficial. It's found in the deep, as you can see here. That correlates nicely with the hyperreflective lesion, which you can see on the structural slab. And then here I've superimposed the depth-encoded flow onto the structural slab, so you can see the lesion corresponding to the hyperreflective foci in the deep retinal layers. This was very important for me in understanding what's happening in type 3 neovascularization. It's through my work with Christine Curcio doing direct clinical pathologic correlations, and we were lucky to have a type 3 neovascularization case that we could study. So the most important aspect of this, at least in my opinion, is what we see right here. What I'm pointing out there is a very thick layer of basal laminar deposit. Nearly all eyes that have type 3 will have this. It's seen as a splitting of the RPE Bruch's complex. And the most relevant finding was that we're seeing Mueller cells breaking through the basal laminar deposit and inserting themselves underneath that. So that forms an adhesion between that rigid material and the retina, which is why we never see a separation. The neovascularization may be secondary. I think this is really the proliferation of Mueller cells. I mentioned that earlier as a comment that drives us and really defines this entity. Here's just an example of from one of our other donor projects, a very thick basinal laminar deposit. So we don't think about this when we do OCT, but this can be easily 50 microns thick. It's visible on spectral domain OCT. So dense B scan OCTA is a technique to get better quality structural B scans with flow overlay. The emphasis of OCTA has been mainly on phos visualizations, but I like to see things with greater detail. So it's just doing a lot of averaging in a small space. So here's a typical case, and you can see the structural details, but you can also see the flow, and what's most important, you see the flow and the penetration through a defect in the RPE. That's the Mueller cells presumably breaking through into that basolaminar deposit. There's the split RP Brooks membrane there. And so really, for me, and this is just my definition, to call it type 3, I think you have to have intraretinal proliferation, not just vascular changes. Plus, you need to see evidence that the lesion has implanted itself through a defect in the RPE into basolaminar deposit. Here's just a sequence of a lesion that's been treated with intravitreal anti-VEGF therapy, PRN. So you can see the fluid comes, the fluid goes, and the flow increases when the lesion is active. You can see the splitting of the RPE Brooks. All these eyes have this. Not all AMD eyes have this, so it really sort of shows us why this type of an eye gets type 3. Here is just the lesion, and again, intraretinal neovascularization and implantation of Mueller cells, presumably into basolaminar deposit. So as I go back and look at some of my older cases, I realized that probably many didn't meet this definition. So here's a 74-year-old male. Is this really type 3? So here is about almost 3 years of track scans, and I've been treating this with anti-VEGF therapy every time I see fluid. But I don't think that this is really neovascularization. If you look very close, there's really just one single sort of aneurysm there. If we apply projection artifact removal, you can see the flow is just confined to that one lesion. And here we can see that little aneurysm with the DB OCTA technique. And so and this is just, again, track scans over multiple months. This is what we would call a PVAC. I don't have time to explain that, but this is a microvascular abnormality seen in these types of eyes. But I don't think there's true proliferation, although there may be penetration of Mueller cells. Here's another case. Is this truly type 3? There's some intraretinal blood. Here's the sequence that preceded. You can see that this patient develops cirrhora before the lesion develops. So there's an avenue for the Mueller cells to penetrate prior to the development of exudation. And here you can see that there's the implantation and the flow. So this would meet my definition of type 3 lesion. Here's just looking more carefully at the different slabs color-coded with DB-OCTA. And here you can see a correlation between DB-OCTA color-coded and then the swept source color-coded on FOSS, and you can see there's a very nice match between what we see with the spectral domain technique on the left and the swept source technique on the right, and we can see the blue flow in the deep. This is a very interesting case. So this is a patient, and I didn't realize what this was until now, you're looking back years before. So 79-year-old woman with AMD. Here's the angiogram. And there's a lot of things going on there. There's some areas of leakage and staining. So the question is, which of these 4 lesions is actually type 3? Voss or David, do you want to take a guess which of those 4 would meet my definition of type 3? No? This one? This one? Yes. Okay. I think you might be right. All right, so this is just looking at the leakage on the angiogram. I've just sort of isolated those pixels, and you can see that that's where we have actually sort of more leakage. And that's sort of the areas again. All right, so we have this area. That's what I showed before. I mean, whether it's you want to call it an aneurysm or a PVAC, that's all that is. It's not a neovascular lesion. Here's a cluster, 2 little microaneurysms, and eyes that have these features get these microvascular changes. Here's an area of cirrhora. It looks like some people would call this a vascularized drusen. There's no flow in that lesion. That's just a window defect and some staining there. And here's the type 3. You can see that the OCT does show implantation through the defect, and so that would meet my criteria for 3. Now, finally, there's this lesion, which I don't know what to call this. It hasn't been described in the literature, and I have 2 cases exactly like this. So I follow this patient, and all of a sudden he has fluid in the retina. But it's up in the sort of more superficial. You can see the leakage is surrounding just this vein. So that's a vein that's draining a certain area of the fundus. The yellow is where the leakage is, surrounding that and showing it around that vessel when I overlay the on FOSS image. And there's the vessel again, and you can see as we go deeper, right there, there's no connection between that vessel through the ONL, and so it's just a leaky venous segment. I mean, I don't know what to call it. That's it there. There's fluid there. It responds to anti-VEGF therapy, but it doesn't meet my definition of type 3 because there's no proliferation and there's no penetration. There's no vein occlusiveness. So in summary, the dense B Scan OCT and correlating that with histology has helped me understand what is really going on in type 3. I still think there's a lot more work to be done, but to meet my personal definition, there really has to be retinal tissue penetrating through a defect in the RP into that basal laminar deposit and true evidence of neovascular proliferation. And so I thank you for your attention.
Thank you, Dr. Bailey, for giving us insight into a difficult topic and also making us wiser where we get confused with various other conditions. We move on to the next talk by Judy Kim. She's going to talk to us on best measures for foveal avascular zone in OCTA.
Good morning, everyone. I would like to thank the meeting organizer and especially Vishali for inviting me at this wonderful meeting. Studies have shown that people with symmetric facial features are considered more beautiful. When it comes to eyes, we often assume that two eyes are symmetric. As a result, in uniocular conditions such as this man who underwent plaque therapy to the left eye, we use the right eye as a control to study what's going on in the left eye. But are the two eyes of our face truly symmetric? In order to answer this, you also need to know that there are many different ways to define foveal avascular zone. Area, axis ratio, acircularity index, major horizontal axis. All these have been described in the literature. Let's go over each one of these more specifically. FAZ area is the one that's been described the most often and published, and it utilizes a special equation to calculate. Axis ratio is a comparison between the longest and the shortest diameter of the FAZ. Acircularity, on the other hand, is a ratio between the true perimeter of the FAZ and the perimeter of a circle with the same area of the FAZ. So if it's a perfect circle, it will be 1. With increasing acircularity, there is thought to be an increasing disease severity. And finally, major horizontal axis is where the angle at which the major diameter occurs from the horizontal axis. So we wanted to answer these 2 questions. Is FAZ truly symmetric for a person? And how do these 4 different metrics compare? And as we study OCTA more and more, it will be important for us to know as to which one we should be using. So we looked at our 170 normative data of subjects aged between 7 to 77 years old, mean age of 27, using Avanti system. We imaged both the left and the right eye to look at the difference between the 2 eyes. And then we also measured axial length for all these patients. 2 3x3 scans were taken to look at the repeatability, and then superficial layer was exported. And each image was segmented twice by a same observer to look at segmentation errors. Then the coordinates from image J were saved and entered into a MATLAB custom program, which was described by one of our graduate students who published on this back in 2017. And each of these metrics were then undergone a multivariate component analysis. And so we have intersubject variability, segmentation variability, repeatability, and the interocular symmetry assessment. And anything that was left over was considered residual to make 100%. And this was our findings, and let's go over each one of these. First of all, the FAZ area appeared to capture the individual difference between subjects the best, and most of the variation came from this intersubject variability. However, we also found that even within normal subjects, there was wide range of FAZ area, ranging between 0.017 to 0.666 millimeters square with average of 0.267 millimeters square. And there was no statistically significant difference between the two fellow eyes. So if we use FAZ area, indeed we can assume that the fellow eye is symmetric. One caveat for using FAZ area is that you have to measure axial length, because between hyperopic and myopic eyes, if we were to do this without correction of axial length and then with correction of the axial length, you actually do get different measures. So axial length is important for using this method. Axis ratio, we found that there was both inter-subject variability with average of 1.22 with range of 1 to 3.79, as well as intra-subject variability. And in this measure, we did find that there was a statistically significant difference between left eye and the right eye. And we feel that it's due to the high degree of variability in the shape of the FAZ, even within an individual between the two eyes. Acircularity, we found that there was a relatively low overall variance between subjects, and the range between subjects was quite narrow, 1.02 to 1.69. And as such, small difference in FAZ contour resulted in a significant contribution to this variation in the acircularity. However, when we did paired t-test, we did not find that there was a significant difference between the two eyes. Finally, horizontal axis angle was one of more problematic measure for FAZ. In order to be considered normal, the angle should be 0 or 90 degrees plus or minus 15 degrees. However, Freiberg and colleagues showed that 28% of healthy controls have abnormal FAZ axis angle, and we also found that there was a huge variation, huge range using this horizontal axis angle, anywhere between minus 89 to plus 89 degrees. Furthermore, we found that the head position of the subject made a huge difference. For instance, if a subject was imaged with untilted head position, we got minus 65 degrees. But however, when we had a subject with different head positions, depending on the amount of tilt, we got different axis angle. So head tilt may affect visit-to-visit measures, and which machine you use also made a difference. For instance, here's Avanti, and here's Zeiss. There was a 6-degree difference in order to overlap these two images, and as you know, different images will have the patient have different head position. So depending on the head positioning and depending on which machine you're using, you may get different answers using horizontal axis angle. So to answer the question whether our eyes are symmetric in terms of FAZ, if we use FAZ area, we can indeed say that they are symmetric. And we also found that there is a wide variation in size as well as shape of FAZ. And FAZ area seems to be best measured for inter-subject difference if you are trying to measure how the subjects differ between ages or diseases, etc. However, in order to be accurate, you do need to measure axial length to account for the magnification. On the other hand, horizontal axis angle may be more difficult measure to do on an ongoing basis from visit to visit in monitoring the disease. But I think in summary, in order to know exactly what's going on, more studies are needed, and perhaps combination of some of these FAZ metrics may be necessary. But as we study more, we'll be able to figure out what metric to use for which disease, and as we follow patients versus cross-sectional studies, some metric may be better than the others. Thank you so much for your attention.
Thank you, Judy, for a very, very interesting talk. So with this, we move on to David Sarraf, and his talk is on AMD Masquerades. Thank you, David, for coming.
Thank you very much to Vishali and his boss and the organizers of RISHI and VRSI2018 Masquerades, and then I'll ask Voss and Bailey if they know what the relationship of these photos are with the title of the talk. You can think about it and then give me the answer at the end of the talk. So here are my disclosures. So the focus of this talk will be on neovascular AMD and pachychoroid syndromes and how they can, there can be entities that can masquerade as those diagnostic entities. But I also wanted to talk briefly about non-neovascular AMD and GA in particular, because there are many more rare entities that can be confused with GA and AMD. This is a patient that has GA on the fundus autofluorescence, a beautiful image showing the large cookie cutter lesions of hypoautofluorescence that's in our atlas, and looks like classic GA, although you don't have the drusen. And this patient actually had a genetic dystrophy, which was identified as spinocerebellar ataxia 7, or SCA7. This patient also has geographic atrophy, but there is that hyperautofluorescent rim suggestive of a cone rod dystrophy in this particular case. Some areas of GA can be associated with a golden tapedo reflex, which is a pathognomonic finding for a COD1 or an RPGR mutation. And here you can see on the full field ERG, a significant depression of the photopic and flicker cone response, which can be very helpful in elucidating the cause of geographic atrophy. And as I say, there are various hereditary dystrophies that can present with geographic atrophy. The full field ERG can really direct you in terms of the genetic testing, and so that you don't confuse these with more common entities such as AMD. I think in the presence of drusen, geographic atrophy can be much more challenging to diagnose. This patient has multiple drusenoid deposits associated with GA, but when you obtain fundus autofluorescence, you see a peripapillary sparing of the drusenoid deposits, and some of those deposits actually have a triradiate or pisciform morphology, which is a clue that this is Stargardt's disease. You can see the dark choroid, which is also suggestive. Giovanni Starengli very nicely has shown that in Stargardt's disease, there's complete loss of the choriocapillaris, so you see dark atrophy with the ICG, whereas with AMD, it's more incomplete, and you see hyperfluorescent geographic atrophy with the late ICGA. On OCTA, it's also very interesting. You can see more fulminant loss of the choriocapillaris with Stargardt's, whereas it's more rarefied or thinned in AMD. And what's very interesting, in the neighboring areas on OCTA, the choroid is intact with Stargardt's disease, whereas it's rarefied and thinned and attenuated in AMD. So these can be additional multimodal imaging findings that can help you distinguish Stargardt's with GA, because Stargardt's can masquerade as geographic atrophy. How about neovascular AMD and pachychoroid syndromes? Can they be mistakenly identified? Well, we have a whole case series of these types of patients. This particular patient was one of the first to launch this particular study. This is a 44-year-old male, had macular detachment with thick choroid in each eye, and had been receiving injections and laser therapy for years with the mistaken diagnosis of pachychoroid syndrome / AMD. When we did fundus autofluorescence, we could actually see a real symmetrical nature with hyperautofluorescent material. And in fact, an EOG was obtained, and this patient had absent light rise, and this was actually Best disease that was masquerading as an AMD / CSR syndrome. We were then able to identify a dozen other cases similar with chronic macular detachments, patients who were being treated for years with anti-VEGF therapy and sometimes even laser therapy, subsequently genetically diagnosed with Best disease, as in this case that was referred, I believe, to Bailey in this study. This is another example of a patient that was mistakenly characterized as chronic CSR, bilateral macular detachments. The family screening was done, and this patient's siblings had identical FAF and similar OCT findings, and the diagnosis of Best disease again was identified masquerading as an AMD / CSR syndrome. Truth be told, hyporeflective macular detachments have been previously described. Bailey and Rick Spade originally described these. The question is, why do these develop? I think the thought is perhaps that the vitelliform material breaks up. And in fact, in many of our patients who had en-face OCT, we could pick up this hyperreflective material, which may be old vitelliform debris that is accumulated in the subretinal space, while most of the active autofluorescent material has kind of taken on more of a fluid component and masquerades as this hyporeflective macular detachment. And here you can see the high magnification of these macular detachments showing hyperreflective debris in the subretinal space that may represent old vitelliform material in these best cases that are masquerading as AMD and CSR. What's also interesting in these cases is that a lot of these patients have thick choroids. They're older patients without a history of Best disease, and yet they have pachychoroid syndrome, and you can understand why they would be misdiagnosed as CSR or AMD. And in fact, our fellow was able to do a survey of the choroid and found that the choroid thickens, at least in our Best population, in comparison to the normal population. And so there may be this association of pachychoroid and Best disease, which may be driving fluid in the subretinal space. This beautiful paper actually shows some immunohistochemistry of the pathogenesis of Best disease, in which you have Best disease is a RPE channelopathy, and it leads to disruption of the microvilli, which interdigitate and encapsulate the cone outer segments. And that leads to actually to the macular detachment. And the thought is perhaps that a thick choroid may be further aggravating this macular detachment in these Best patients as they get older. So in conclusion, Best disease can present with macular detachment and masquerade as AMD or CSCR. These patients can receive needless anti-VEGF and laser therapies. The pathogenesis is a channelopathy leading to apical microvilli disruption and loss of cone outer segment interdigitation, and this can be further driven by a thick choroid causing fluid in the subretinal space. In the last minute, I want to show you this final case of a patient, again with macular detachment and thick choroid, who was mistakenly diagnosed as a pachychoroid syndrome or AMD, had received multiple anti-VEGF injections and laser therapy. And again, I thought that this was Best disease masquerading as AMD/CSCR. But in fact, we did genetic testing, and the patient did not have Best disease. With en-face imaging, we were able to rule out neovascularization. And in fact, on the en-face OCT, you can see these characteristic radiating hyperreflective lesions, which were very interesting in both eyes. The EOG, as I mentioned, was normal. This patient did not have Best disease. But if you look at the fundus autofluorescence, you'll see this pattern-like change in both eyes that was suggestive of a butterfly dystrophy. And in fact, this patient's macular detachment was a peripherin RDS mutation, so another example of an AMD masquerade syndrome. So beware of these genetic dystrophies in patients that can be misdiagnosed, and these patients can receive unwarranted injections and laser therapy without a proper diagnosis. So back to the first slide. What is the relationship of this title to these two photographs? No, it is The Who. So The Who, this is the group The Who, one of the most famous rock bands in the history of rock and roll. And Don't Get Fooled Again was the title of one of the famous songs on this album, Who's Next. Very good, Vas. All right, thank you very much.
Thank you. Thank you, David. Our next speaker is Dr. Faisal Beg, and he'll be talking on retinal biomarkers extracted from OCT images.
Thank you very much, and thanks to the organizers for giving me this wonderful opportunity. I'm so glad to be here. My talk is more on the technology side of OCT imaging, not on the clinical side. I am a professor at the Simon Fraser University in Vancouver, Canada. Vancouver is this one amazing place where you have the mountains of Kashmir and the ocean of Kanyakumari. So if you have one city in the world that has both Kashmir and Kanyakumari, It's Vancouver, so I highly recommend you come and visit. I'm going to present the work done by my team here. We have a very nice team where we have a OCT hardware specialist, Dr. Marinko Saronic. He designs research-grade advanced OCT scanners. I work on the algorithms that make measurements from OCT images, and then we have the clinical team, and we embed our hardware and software in the clinical side to learn from what the clinical needs are and to design algorithms and hardware that's actually useful in the clinic. So I'm going to be talking a little bit about the work that is done by the team and the trainees, all taken together. The motivation, as we know, is that, as you've seen on all the sessions this morning, OCT is providing these amazing, pretty pictures of the human retina. Now, these are still pretty pictures, and the analysis is mainly qualitative and visual. In order to actually make the analysis quantitative, we actually need algorithms, and we need these algorithms to allow for better disease classification, monitoring of disease progression, and also to check if the treatment plans that are being prescribed are actually working, and if not, maybe modify them to better suit the patient needs. Now, if you want this quantification to be clinically useful, we have to have automatic algorithms, because I'm sure none of you in the audience would actually want to spend your time manually outlining and measuring things from OCT images. It's really so tedious. Some of the examples that we can actually, where we can design algorithms, are making retinal layer segmentations and thickness measurements and using them in different treatment plans, microvasculature from OCT angiography images, and density of microvasculature, fluid segmentation from macular edema kind of images, and many more. So we have been working on these algorithms. So I wanted to talk to you about 3 tasks that we've been working on recently. First is to classify and segment fluid regions from OCT images automatically. The second is to segment retinal vessels from OCT angiography images automatically. And the third is to identify in adaptive optics OCT images, photoreceptors, cones automatically. I may not have time to go through all 3 of them, so I'm going to try and focus on task 1 and leave tasks 2 and 3 for offline discussions if there's interest. So deep learning has revolutionized the analysis of OCT images in the last 5 years. Actually, it's revolutionized whole industries in the last 5 years. Before deep learning, image analysis was done by practitioners like me who would use models, model-based image analysis, where the model was you have to teach the computer what to look for. For example, if you're teaching the computer to look for fluid, you tell the computer, okay, look for a contiguous band of pixels in the image that are darker than the surrounding and a certain size and a certain shape. So we would actually use our a priori knowledge of what a fluid should look like and tell the computer to look for exactly those patterns. Now, with the advent of deep learning, we don't need to do any of that. With deep learning, what we have to do is to give the computer lots of images and lots of examples of manual segmentation of what the fluid is. And the computer will itself learn what features are the ones that describe the fluid and automatically find them in OCT images. And it's really powerful. As an example, so this is based on this field of neural networks, which has had a renaissance in the last 5 years. The example shown here is we want to classify these handwritten digits, 0 to 9, on what the number actually is from pictures of those digits, so handwriting on postal letters, for example. So each of these digits is, you find these in a image of 28 by 28 pixels, so there are 784 scalars or measurements or numbers that describe that picture. So you feed that image, those 784 numbers, into this network. These are neurons. They sort of mimic human brains' neurons, but basically they essentially take an input and scale it, multiplied by some number, and add them together, add or subtract. Now the number, the scaling and the addition subtraction is an unknown parameter of these neurons, which is learned by the neuron when you train it. So how does training happen? So you feed this image into this neuron network. These neurons do adding, subtraction, scaling on these images. And then at the end, out comes a probability of whether this image, what of these digits is this image. So the neuron will output a probability, of course, in the first few instances, because the parameters have not been learned, there'll be a lot of error. But the error will be then fed back to update those parameters to generate better and better outputs. And this way, the parameters of the network are learned. There's been a lot of literature now in the last few years on applying machine learning, specifically deep learning, for quantifying OCT images. And so, there's a bunch of papers I've listed over here, and a lot of things are happening that are coming on the horizon. So this field is set to revolutionize the entire field of clinical image interpretation in the next few years by providing quantitative metrics. Now, there's always this worry that clinicians have, what if these algorithms become too powerful, or what will be my role in all of this? And in fact, I'm going to tell you the opposite. As an image analysis person, I'm worried of the opposite. The opposite is that these algorithms are becoming so easy to use that I'm worrying that in a few years, clinicians will be able to download these algorithms themselves and train them themselves. So there'll be no need for image analysis people like me to design these algorithms as well. So there's always something to worry about. Okay, so here's this first task. We have these three kinds of fluids. They've been talked quite a bit in detail in the sessions in this morning. The IRF, intraretinal fluid, subretinal fluid, and pigment epithelium detachment. We want to design an algorithm that can take an OCT image and output these segmentations for the clinician to analyze. So peering the curtain a little bit on the nuts and bolts of this algorithm, the raw OCT image goes into the neural network on this side. There's a few pre-processing steps like motion correction, BV smoothing. It's called bounded variation smoothing. It essentially reduces the noise by preserving edges without damaging the edges in the image, like the retinal layers. And then we do a 3D graph cuts. It's an algorithm that finds the inner limiting membrane and the Brooks membrane automatically. And once we find these, we can reject all the pixels that are outside these two and focus on the algorithm on classifying the pixels within these two layers. Then we create a distance map where each pixel gets a number or a distance of itself from the ILM and the BM, which helps it to detect the location of the training sample that is given, the fluid regions in the training sample. And then the core of this network is a deep network, a fully convolutional network over here. And then it is designed to over-segment the fluid region. So it actually calls more regions as fluid than they are in the image. A second layer of classification then takes those candidate fluid regions and rejects those that are not fluid regions based on the patterns it has seen from earlier training examples. And in doing so, it comes up with a final fluid segmentation. All right, so I'm going to skip a lot of details for this deep network. I can cover this offline. We participated in this imaging challenge in this conference called MICCAI, Medical Image Computing, Computer-Assisted Intervention, the top conference in the field for these kinds of tasks. They gave out 70 training volumes, which are manually segmented with fluid. We use those. These are based on these three scanners, Zeiss, Heidelberg Spectralis, and Topcon. And then they gave 42 testing volumes, which did not have ground truth. And so we had to predict which of these volumes had what kind of fluid and submit those results back to the organizers who checked the accuracy and gave us the results. So here are the results. These are representative sample images from this challenge. The original B scans are given on the top row from these three different manufacturers. The segmentations in IRF, SRF, and PED are given in the bottom row, as shown that these are really quite nice, and they work really well across the entire database. Some quantitative examples, quantitative segmentation results. So Dice coefficient is a way of measuring overlap between the manual segmentation and automatic segmentation. And the Dice coefficient of all of these three scanners for all of these three different kinds of fluid is around 85 to 90%. Now, when we look at between manual rater agreement, that's also about 83%. So these kinds of networks are actually performing at the level of a manual rater than by itself. And it does so in a much smaller fraction of time. Here is a prediction of whether a OCT volume actually contains fluid or not. So on the horizontal axis are the number of volumes, 42 volumes, the testing volumes. On the y-axis is the probability of whether that volume has OCT, has fluid in it or not. So we can see that those red lines can actually distinguish between OCT volumes that have that kind of fluid or they don't have the kind of fluid. And the detection performance, which is the ability to detect whether an OCT image has a fluid or not, is actually 100%. So this algorithm we designed was 100% perfect in finding which OCT images have or do not have fluid. And that could be quite useful for a clinical pipeline with a lot of throughput, where lots of scans have to be analyzed, in prioritizing which of these scans to analyze. On the bottom row are the results from the competing teams in this challenge. This is an international challenge, and our submission came out to be at the #1 position, at the top position. So we won that challenge. Then we also applied this to an unseen data set, and we found that it actually does really well on an unseen data set as well. I can stop there, and this completes the first task, and I'm going to leave the second and the third tasks for offline discussion. Thank you.
Thank you, Dr. Beg. I'm sure you have lots of questions, so we have half an hour. You can ask any speaker, and Aniruddha and Sudhir are going to moderate the panel.
Thank you. So we have about half an hour for a panel discussion, and I would like to invite my co-moderator, Dr. Sudhir Salhotra. And we have the panelists for our session. Dr. Atul Kumar, I don't think he's here. We have Dr. Mahesh Shanmugam, sir. If you can come on the stage, please. Dr. Michael Stewart. Dr. Hani is here already, and Dr. Wei-Chi Wu. And also like to invite Dr. Bailey Freund, Dr. Sarraf, and Dr. Glenn Jaffe, if you can join us on the stage, please. So we'll try to answer most of your questions from the audience. So, yes. Dr. Adrian Koh. So we'll try to take as many questions from the audience as possible, and we'll have sort of a focused discussion on the biomarkers of disease prognostication for this session. So we'll begin with Dr. Jose.
Thank you.
Go ahead, please.
So this is to Dr. Judy Kim. And I was just wondering, you had a group of normals, but you did you sub-segment this group of normals for looking at the FAZ into age ranges rather than lumping them all together? Because I have to wonder whether rheologically, even though a 70-year-old is still considered normal, whether the rheology of blood going through those endothelial cells causes damage to the FAZ, and whether there'd be a greater chance of asymmetry in a 70-year-old versus a 5-year-old.
Sure. Thank you for the question, Jose. We had 170 subjects, which is actually one of the largest of the normative data. And yet even then, when we spread it out into age groups, they are skewed more towards the younger group. Our mean age was around 27, even though the range was from 7 to 77. So we probably would not have enough data in the older age group, such as the 70-year-old, a decade group, to be able to answer that. Also, the flip side is that, perhaps it might be interesting to follow an individual over life cycle to actually answer your question. That would be the only way, I think, to see whether there's truly a change over time. Thank you.
So I think we can, before Dr. Rupesh has a question there, but before that, we can just go ahead with a discussion on OCT angiography first. So in the talks in the morning, we had Dr. Jaffe showing us some interesting cases of neovascularization. And I'd like to ask him a question. When you see a network on OCTA but no fluid, so what are you exactly thinking? Would you like to inject? Would you like to defer? What's your thought process behind evaluation?
The question is whether this is a clinically silent and possibly beneficial choroidal neovascular membrane, or whether it's something just waiting to happen and produce exudation that you'd want to treat. And I'm not 100% sure that we know, just looking at it, which of those paths that it's likely to go towards. And usually if I see that, I'll watch. And I'll watch carefully. I might see the patient more frequently than I might otherwise, because if I start to see signs of exudation, I'll definitely want to treat. But I've also seen cases where I think geographic atrophy has been somewhat protected by the potential presence of these clinically silent choroidal neovascular membranes. And in that instance, I don't want to be treating. And so I usually take a very careful, close watch approach.
Dr. Rupesh, you have a question?
Yeah. My question is again for Professor Judy. You presented numerous factors which can affect FAZ area, and one of the factors, and you presented your data in square millimeter. Now my question to you here is, whenever you do on the MATLAB or ImageJ or any of the image calculation, you get the numbers in the pixels. How do you convert pixels to microns? Is there a change? Because when you take the same patient image 3 times, there will be every time you get different pixels. So how do you convert it consistently over whatever number of scans? Maybe Dr. Beg can answer also, and Professor Judy, if you want to take up this question.
We have an algorithm that's been developed that our lab has been using, the Advanced Ocular Imaging Program lab has been using. So our graduate students pretty much use that algorithm for all of our projects.
But if you see those scans, and I'm sure all the image experts here, they will know, when you see those scans, if you take an image for a person, 10 consecutive scans will have 10 different pixels. And when you use the same algorithm to convert those pixels to micron, every time we'll get a different value. So that's my main worry whenever we present this in the millimeter. So those pixels are going to change every time. How are you going to be consistent? Adnan, you want to answer?
I can try and answer that.
Yeah.
As a thought, so normally you'd have an internal calibration with ImageJ or an equivalent program, but I understand what you're meaning. If you do repeated scans, there's a magnification error, and then you have to calibrate each individual scan. What you should have is an idea of the measurement error and put that into your statistics at the end. So there will be a measurement error because I suspect they're just going to calibrate one image.
Yeah, because we have to feed it ourselves.
To do that with the pixels.
When we start calculating it, we have to feed it how much microns is equal to pixels, or how much pixels is equal to micron before we actually get that. Yeah,
So,
Dr.
yeah, I mean, a lot of these fundus camera systems, they're based on a Model I, right? So the original Incis's original fundus camera, they used a Gulfstrand eye, and a lot of the pixel to millimeter conversions were determined based on that. With the Optos camera, we had published on using an intraocular ruler, basically a retinal prosthesis, as a way of confirming that the software, that the system was giving us accurate readings. So we have some external validation. The good thing with a lot of those CTA scans, at least they're isotropic scans, so you don't have the weirdness of pixels that are not square. I mean, these are all square pixels, generally, these acquisitions. But basically, fundamentally, some of the systems actually automatically do some degree of adjustment for the axial length, some don't. But fundamentally, you're correct. There is an innate inaccuracy in that a lot of them are based on assuming that it's a Gulfstrand eye. Yeah. And if it's the same patient followed longitudinally, it's probably okay. But if you're doing, those of you who are doing studies where you're including high myopes, patients with normal refractive errors and all in the same bucket, you may get variances just based on the issues that you're raising.
Okay, Dr. Ranjit.
This is a question for Dr. Adrian Koh. In your excellent talk, you suggested that some level of subretinal fluid is kind of protective towards, let's say, geographic atrophy. So when you look at that, and then we go back to, looking at pro-renata treatment vis-a-vis treat and extend treatment, where you would treat, even an eye that is absolutely flat of this thing. So should we, in this light, consider that kind of a very intense treatment? Does that really lead up to geographic atrophy? Is it good to leave a little few pockets of micro, pockets of fluid, or do we, go for aggressive treatment?
Thanks, Anand. I don't think we have definitive proof, but I've just had a chance to review the results of the fluid trial from Australia, and Mark Gillis, I don't think is here yet, but we can discuss that with him. Very clearly, I think now more and more consistency that the presence of subretinal fluid is not damaging to the final visual outcome, at least in the short term. Does that mean that we don't intend to treat all fluid compartments? The answer is no. When you have treatment-naive patients, you want to dry the macula as much as possible. But if you can't, right, and you still have that residual subretinal fluid, you don't need to chase it till the death of the photoreceptor. And therefore, you can consider an extension of the interval, but always watching what happens. Does the fluid increase? Does the vision drop? Do you get new hemorrhage, right? So you can always pull back later, but it doesn't mean you have to keep treating at 4-6 weekly intervals because you've still got some subretinal fluid.
So are we at some sort of a consensus? Are we arriving or moving towards some?
I think we need to. I think at some stage, once we have enough data, we will have a consensus around it.
Well, I have a question for Dr. Koh. We are talking about the biomarkers. Do we have a biomarker on OCTA
where we can predict that this dry AMD is going to get converted into a wet AMD?
Short answer, no. Glenn?
No, not yet.
But we're hopeful that the choroid capillaris may provide a clue. At least, this is work that we did in collaboration with David, but we do know that, for example, if you look at the fellow eye of patients with neovascular AMD, even that fellow eye shows significant choroid capillaris deficits. What we're all lacking is the longitudinal evidence to show that those patients who have more choroid capillaris injury actually manifest a reactive CNV response. We suspect that. It's a theory, but to Adrian's point, we don't know yet.
And there's still going to be
Can
some...
we compare the flow rate or regarding the flow rate in the eye, measuring the flow rate, can we predict that this can go into a into a wet form?
Well, we really don't get a flow rate out of OCTA so far. You can maybe tell with some of the VISTA-based analysis some idea of slow or fast flow, but we really haven't been able to do that in the choroid capillaris. So no, really we're just looking to look at the total flow deficit. But I think Glenn...
Yeah, I was just going to mention, though, what you said is to be able to predict, and I think to predict with a certain probability, because there have certainly been cases where you have flow deficits in the choriocapillaris that don't go on to develop problems and vice versa. And so I think ultimately we're going to end up with a probability that you progress and not an actual, in any individual case, no for sure.
We're seeing all the time now patients that have non-exudative type 1 or sub-RP neovascular membranes. And we have data from Phil Rosenfeld's group that those patients are at higher risk for conversion. So that's one thing you can look for. And it's not that uncommon to find those. And many of the patients that have this disease that sort of overlaps between AMD and central serous, I call it pachychoroid neovasculopathy, you can call it whatever you want, but that's a very common finding. Although those patients will rarely present with hemorrhage. It's usually fluid, and I'm not as concerned about those as the non-exudative type 1 membranes in true AMD eyes. Those need to be monitored closely.
Dr. Hamza, do you have?
Yes, I just want to come back to the first question you have here, that if you have a patient without fluid and a network on OCTA, would we inject or not? And Dr. Jaffe said that we will defer the injection. In patients on treat and extend regimen, we inject without the presence of fluid. Is there any evidence that these patients develop geographic atrophy at any stage, more than patients on PRN?
That's a good point.
Can I comment on this? So this may sound a bit sort of illogical, but I think the most likely treatment we're going to have in the near future for atrophy in eyes that have neovascular AMD is using the neovascularization to prevent atrophy. So we do not see atrophy occur over these shallow areas of neovascular flow, or very rarely. So I would be cautious about treating to the endpoint of complete dryness. I like to use the fluid to know that I'm not over-treating. And if I see a patient that has, to get to the question, if I see the patient who has a non-exudative type 1, I have cases I can document with ICG. That was a plaque that now with OCT now almost involves the entire macula. It is possible for that type of tissue to never leak, and those patients never get atrophy. So if we can use that when it's there, and it's not always there, that's one way we can use the disease to sort of treat itself.
Yeah, and I think that to Bailey's point, which was actually partly the point I was making as well, we have data, at least from CAT, to show that an increased number of injections is associated with a higher rate of atrophy. And in the first year, patients who were treated monthly and then switched to a PRN regimen, the rate of atrophy dropped down to the rate of the PRN treatment arm, which was less than the monthly treated arm. So I think there is something to that.
But do you think that's due to the anti-VEGF? That is it that causing it, or is it sort of more of an indirect effect of of switching and then maybe allowing this tissue to grow? There's certainly many patients that I think I could treat every month that would never get atrophy. So I wouldn't use that as an excuse to not treat certain eyes. But yes, if I have a patient that has a type 3 and it's regressed to nothing, I'm not going to treat that patient every month. That's probably putting them at risk.
I'm uncomfortable to say this because I'm always worried about comparing between studies, especially when one is a smaller study. But I will say, in the TREX AMD study, which was a small study of looking at treat and extend versus monthly therapy, which showed good visual outcomes, we did see substantial atrophy, and that we had monthly OCT. We even had autofluorescence in that study, so we were able to study this question very carefully. We did find a faster growth rate. We've published on that in the treat and extend eyes compared to the fellow eyes without CNV, and that is counter to the Harbor trial, where it was a PRN treatment that was used. We didn't find that type of a difference in Harbor. So I don't know. So the real answer is, despite all of that, I don't know. But there may be some reason to think about that. So I don't know if that's going to mean that we're going to stop doing treat and extend. I'm certainly not suggesting that. I want to be clear. I think that's still a very reasonable and excellent treatment strategy, but your question is a good one, Dr. Sudhir. I don't know how that's going to turn out. Yeah.
So we're short on time. We have lots of questions. Let's take two questions.
One question here. So, you know, you have a patient who has got fluid, you treat them, inject them, it becomes dry, and then you're worried that it may develop a GA. In India, the problem is economics. So in this case, if I inject a few more injections and it make it dry forever, will that be a better option than to have it PR and then the longer term, again come back, again keep injecting, and you know this cycle goes on forever?
So before we answer that question, let's take Dr. Kothari's question as well. We can answer both probably. Yeah.
Yeah, so my question to the panel and specifically to Dr. Beg is, we are doing work that is quite similar to yours. Only thing is that we are using watershed transform instead of your graph cut method in the beginning. Now, I had three questions, one leading to the other. The first...
Yeah.
Yeah. So my question is, we are doing the similar thing. He's using the graph cut method, we are using a watershed transform method. Now, there were certain difficulties in using deep learning methods that I wanted to get your opinion on. The first thing is with different platforms, be it Heidelberg or be it Cirrus, noise is different. The noise characteristics are different. So are you using a denoising algorithm, and is it a standard one for all the data sets, or do you have noise reduction algorithms that are specific for a particular data set? One.
Yeah. All right, so the answer to this question is you need to have different networks for different manufacturers because they are all very different. And deep learning, as is being shown now, is very sensitive to noise patterns in an image. You can actually fool a deep network very easily by changing a few pixels in very, very subtle ways that the human eye would completely ignore, but a deep network would completely be thrown into chaos. So we have 3 networks, each specialized for each of these manufacturers. And for the unseen data, we use the Spectralis network trained on MIC-I dataset and applied it to the unseen data because that was also a Spectralis manufacturer machine. Okay.
So Dr. Kothari, before you go to the next question, we have some questions for the panel that we need to cover as well. So let's take a contrary scenario here where we have fluid, but I do not see a membrane. This is something that Dr. Sarraf has really covered very well in his talk. And the question to him is, with his cases of vitelliform and other dystrophies, the next imaging that you do, is that autofluorescence? Do you heavily rely on in your practice, or do you go for other techniques?
Well, first of all, I think that's one of the clinical situations where I think OCTA has become very valuable to me, is when you have fluid, but you don't see a neovascular membrane. I think there are many situations, for example, in eyes with acquired vitelliform dystrophy, you can see fluid in association with the vitelliform lesion, as well as eyes with drusenoid PEDs. Sometimes you can see a little sliver of fluid there. It could be a pachychoroid CSR situation where you don't, even in an older patient, where you don't see a neovascular lesion on the OCTA. And those are situations where I use the OCTA to determine if I need to inject the patient. I think the opposite is a more tricky situation when you see a neovascular lesion and you don't see fluid, and I think that still needs to be elucidated. But certainly the former clinical context is an important one where OCTA can have some value.
Yes.
Can I? Yeah. So when we are doing the PRN or when we are trying to slow down the injections after the initial load,
vascularization, I think it really helps in my management. So I spoke about type 3. Type 3, you treat it, often it responds very well. I often will go to PRN or as needed therapy because they don't come back with big hemorrhages if you follow them carefully. They'll have a little few intraretinal hemorrhages always be in the same spot. So if it's type 3, just catch it. If it keeps recurring, then go to treat and extend. The type 1 that occurs in the pachychoroid, that almost never bleeds unless there's aneurysms. Most people call them polyps, right? So if you have aneurysms, polyp, then you got to worry in that case. But otherwise, hardly ever see hemorrhage. And again, that's helpful in typical AMD. If you see aneurysms, they bleed. But if you've had type 2 that's regressed, if you have a large fibrovascular PED, those are the ones that can present with big hemorrhages, particularly in the older patients if they're on blood thinners. And so those are some general guidelines that I use to predict hemorrhage.
To the second question, which one should I look at more carefully? Who would like to take it?
That question?
Yes.
Yeah, so it really depends on the disease. I showed you diseases where drill was a better correlate to visual acuity than the outer retinal changes, but outer retinal changes are...
Because there is drill or just because there is outer retinal disruption? You would first inject once and then subsequently take a decision, or would you not treat at all? Is there a situation where you would not treat just based on the drill or outer retinal changes?
Yeah, I'm not basing my decision necessarily on whether it's drill or whether it's outer retinal changes. I'm basing my decision on whether I think it's a VEGF-driven exudative process. We talked about the degenerative changes or cavitations, which typically have a more angular appearance, and that I may not be so aggressive about treating. But if I think it's a VEGF-driven process, I'm not really looking at whether it's drill or whether it's outer retinal changes. I'm looking to see whether an anti-VEGF therapy would be likely to treat a VEGF-driven process.
Then what is the real relevance of these when we are looking at it?
I think the relevance can be for prognosis in deciding how aggressively in the long run you may want to treat. If you see drill, for instance, that's persisting, that can correlate with worse visual acuity, and it's something you can talk to the patient about. If you see intact external limiting membrane, you see loss of ellipsoid zone, the intact external limiting membrane can help to predict somebody who at least has the capacity to recover. And so in those instances, if I have a VEGF-driven process, if I have intact external limiting membrane, I'm going to keep treating because I think there's the capacity to regenerate the outer segments and the patient's visual acuity might improve.
Dr. Vedantam, please.
I think Dr. Abhishek's question has not been answered yet.
Oh, yeah.
You are waiting for your answer?
No, it's the second question that I wanted to ask because...
Please go ahead.
Yeah, so the second question that I wanted to ask, because you are using deep learning. Now, for deep learning, you need ground truth marked data sets for the machine to actually learn. And you would probably be using 2 or 3 different data sets from different observers. You would have observed that if I mark and if you mark, we probably will mark cysts, especially the intraretinal cyst, a little differently. How do you account for that? Are there certain standards? There's no publication on this, so are there certain standards for ground truth marking? Do you have certain criteria that you employ at the beginning of your study to mark with different data sets?
Right, really good question. So really there are no standards as of yet. It's a wild, wild west. There are different raters who mark very differently, and that's all part of the noise that the network has to learn from. So actually I think that's a good thing because in that the network actually picks up various patterns and it learns all of them. And so it comes up with an aggregate of all these manual segmenters markings. But in the long run, I think we do need standards set so that we can have standardized databases that can actually be used by all the teams around the world as a common resource, and that helps develop these networks that will actually then be clinically useful and provide something that's clinically valuable.
So just a response, there's ultimately no gold standard. I think the area that's furthest forward is diabetic retinopathy. We've just looked at our inter-observer agreement in our reading center to help train our deep learning algorithms for cysts, and they're wildly off, because if you do a dice on 2 individuals, you just got to be a few pixels off. And so categorically it's right that it's intraretinal fluid, but to actually outline the lesion as a pixel value, it's extremely poor with small lesions on it. So I'm not quite sure how we deal with that. Ultimately, there is no gold standard. It may be we end up arbitrarily having a few experts and saying that's what it is, because it probably doesn't make that much difference, at least it's a consistent error.
So we have just 1 last minute left, so we'll just take a last question from Dr.
Yeah,
Vedantam.
thank you, Aniruddha. My question is to Dr. Koh.
some studies have shown that maybe non-whites are more prone to atrophy when compared to whites. So there's definite racial predilection. Do you find any difference in Asian eyes when compared to European eyes? Because you come from Singapore, when it comes to development of atrophy, because that question may be relevant because we are also an Asian country, India, we are a brown race, and I don't know how relevant it is if we extrapolate, findings from the Treat and Extend and other studies which dealt with mainly European eyes and Caucasian eyes.
So if you look at very large population-based studies and in Asian eyes, the rate of late AMD is really no different from Caucasian populations. And I think it's largely true. That is, if you exclude the pachychoroid spectrum of diseases, which I think is protective against geographic atrophy, just looking at typical AMD, drusen, and then later on developing RPE atrophy, the rates, I think, are no different between Asian and non-Asian eyes. And we need to then treat these patients in the same way.
Thank you. So thank you for to the panel for the wonderful discussion and for all the talks in the morning. I would now like to invite